Thank you. So, Dr. Laird, I'm excited to go through some case studies with you now.
Yeah, thanks, Carol. Me too. I love learning from patients, and all of these patients you're going to hear. I've sort of adjusted things just a little bit for teaching purposes, but all of the basic stories are all ones that I've encountered and have had some good work with my teams to get us through these dilemmas. And so, yeah, case learning is wonderful. So in this particular area, on the next slide, I want to point out that as we think about cases, I specifically did this I called it case discussion, but I'm going to contrast that now with the next slide. Go ahead, Janet, and move to that says person-centered care. Because really what we're talking about are not cases, not case 1, 2, 3, 4, it's people. And no, these are people who are having a problem that none of us want to have. And so this particular issue lends itself very well to person-centered care, doesn't it? And some principles of person-centered care that I like to make sure I'm remembering as I'm helping someone is I really want, when I'm helping someone, to leave them feeling that I know who they are and I know what's important to them. You know, I want them feeling like I know them. I want them feeling like I think they're part of the team. Now, you might have heard me throwing around the word team, and I don't know if you were thinking that the patient was part of the team, but they are. Now, if they have cognitive impairment, they're going to need a buddy. You know, they're going to need an advocate, but they're still part of the team. They're actually the reason behind the team. So yeah, we want to include them. And in fact, we're their advocate. You know, we're there for them. And so these principles of how our care becomes person-centered is really important. So I wanted to share that with you. So with that all in mind, we're going to kind of rapid fire through some of these cases. Again, later on, you can take your time and look at them. They've all got, you know, certain nuggets in them I hope you'll take away from the conversation we've had today. So our first example is Mrs. S. She's 84, she's widowed, doesn't have children. Her osteoporosis is quite severe, osteoarthritis in her hands, and all of that arthritis, then it affected knees and hips, led her to be in long-term care. And she's been there about 5 years. Now, she's an example of someone who has had the arthritis, but cognitively, she's pretty sharp. She does ambulate slowly, and otherwise she's doing pretty well if someone sets things up for her from an ADL standpoint. Now, for about the last 3 years, she's had urinary incontinence going on. And lately she's seemed a little more down and withdrawn. So let's go ahead and learn. So that's her initial background. Let's on the next slide learn a little bit more about her. So this incontinence that she's had kind of smoldering for the last few years is now up to about 10 trips to the bathroom a day, often with leaking, and 4 times at night. The leaking comes with urgency at times. She's occasionally got some leaking where she's trying to like move herself up out of the chair, that pressure, intra-abdominal pressure. No hesitancy or sensation that she can't empty the bladder. No signs of a urinary tract infection or anything like that. She's using about 5 pads a day and then 1 or 2 at night and still wet. So that situation's not ideal either or sufficient. Other information I mentioned earlier to keep in mind about fluids and diet. She is having soft bowel movements. She drinks a lot of water, 6 cups, 2 cups of tea, and a cup of coffee every day. All right, so you may be, I hope, as I'm talking, I hope you're thinking through that list of risk factors, that list of things that can create trouble in an elderly person. I hope you're starting to think of some things that you could think about for this lady. Next slide, please. She's got type 2 diabetes, high blood pressure, some venous insufficiency, and she had a DVT with some cellulitis in the past. Chronic pain from her osteoarthritis. Her gait is increasingly unsteady. So 3 falls last year, 2 in the last 2 months. So the pace of that's gone up. Her medications are, as you see here, and it includes a few doozies, right? So she's got a water pill, she's got a neuropathic medicine, and she's got a sedative benzodiazepine at bedtime, along with a blood pressure medication and the medication for her diabetes. All right, I don't know if there's any pharmacists in the crowd, but they're probably like having hives or something. So, okay, next slide. So what do we learn from her symptoms? This is a classic situation of what I wanted you to remember about, see where I have the word mixed on that far left side? What's the new term that you learned? Multifactorial. That's where we're going to cross out mixed and we're going to put in multifactorial. That's because just like many of our patients, she has more than one thing going on. She has some evidence of functional problems with her arthritis and her mobility issues. She has some symptoms of overactive bladder where she has that urgency and can't quite get to the bathroom enough after the signal came. And she has some stress symptoms where she's increasing that abdominal pressure and the bladder cannot hold itself and it loses some control. So all of those types of conditions are going on. Next slide. And in addition to learning all of that, what you also learned in the beginning of her story, I want you to not forget, and that is she's also having a worsening mood and depression symptoms. And the reason to help treat her, if you think about our cycle of decline, there are multiple reasons to treat her, but do you see how understanding the multiple different ways that she could have contribution to her urinary incontinence would be important as you try to chip away at caring for her and reducing the impact so that her depression doesn't get worse, she doesn't fall on the way to the bathroom, she doesn't have, skin breakdown, all those sorts of declines. So that's kind of my key takeaway there is the multifactorial nature of things. Make sure you're looking for more than one thing, and then remember the downstream effects, and especially if it's in someone cognitively unimpaired, you don't want their mood affected by this in a negative way, as that can be significantly detrimental to their overall quality of life. So then, those types of urinary incontinence, that's where your management comes in, and it's multiple different levels of management. That's why you need your team around you. Okay, I think we'll go on to the next patient. Now this patient, Mr. A, I was very creative with his name. He's 92 years old and he has Alzheimer's disease. Now he's in fast stage 6, so he's in the later stage, but usually awake and active much of the day. He attends all meals, he's ambulatory, no real issues there. Over the past 2 days, he's been more and more agitated and sleeping much more than usual. He's not eating, which is also very uncommon for him. And the last 2 shifts have reported 1 episode each of urinary incontinence. So, and I didn't tell you, but he was fully continent before all of this happened. Okay, next steps. So this is multiple choice, but I'll spare you having to raise your hand. So we either get to call the MD and say he's agitated and ask for an antibiotic for urinary tract infection, or we turn down the lights and reduce contact with others, or we call the MD to report the agitation. We give some vital signs. We talk about his decreased alertness and he's not eating, with new onset to the urinary incontinence, it's not smelling very good, decreased urinary output. Then we turn down the lights, reduce contact with others while we keep a closer eye on him while kind of waiting to hear what the doctor has to say. So without further ado, the answer is letter C. My hope is that you would not simply call for the antibiotic. Now you might say, well, Dr. Laird, you said jump on those acute problems with urinary incontinence. And yes, I did. And that may be the outcome here. But what I want you to do is letter C. Why? Because it's a fuller answer for him. It also shows that you understand he has his dementia and the agitation is being made worse by this urinary tract infection. So he's going to need some additional care. And you're asking the doctor for some guidance on the urinary tract infection, with understanding that you may end up with your antibiotic, but you're not sort of removing the understanding of his whole person and the issues affecting him. So next slide, please. Yeah. So the research would also tell us, I'm using this as a way to kind of sneak in an important point. The research actually tells us that dementia and agitation can go together. But typically they're also, if it's contributing to if the agitation is related to a urinary tract infection, you will most likely also have something new happening with regard to urinary incontinence. You can't or you shouldn't just assume. So you really do want to watch for new urinary symptoms if you want to put those two together. And then, yeah, today, we won't really talk about those last two management points, but you can read over those. Next patient, want to make sure we get to all of these. So Mr. B, he was paralyzed from a stroke. He's not able to stand, doesn't pivot. So he's really dependent on his care team. And he's been using undergarments since he got to the facility about 3 months ago. He also had aphasia, so he can't really speak, but you've noticed, and your CNA has told you, he can definitely understand what I'm saying. So one of you comes and you're just meeting Mr. B, and you put 2 and 2 together about him being able to understand and him having some remaining abilities cognitively. And you talk to him and ask him if he'd rather use a urinal. And he says yes. So then you are able to use the urinal with him. He needs some support, but you're able to use it, and he does well. Next slide. I use this one to just point out that you don't want to assume. Just like I don't want you to assume everyone is going to be incontinent when they're older. You know, don't be very careful, especially with aphasia and cognitive issues. Don't assume that someone can't understand. This is a great example where the team understanding what someone can do and the fact that he could understand taught that team that he could actually understand spoken word. And doing so allowed them to come up with a plan where he was much happier being able to use the urinal at night. And it ended up working very well. And I always like to put this little plug in that urinals can work even if you have to be supine. Now he ended up needing to be supine a bit, but they were also able to help him get to a point where he could be upright. So, and urinals do prove benefit. They help prevent skin breakdown. They reduce the need for cleaning, changing overnight, et cetera, et cetera. So there's a lot in this particular case that I want you to remember. All right, and the last of our patient cases. This is also a pretty common clinical scenario. So Mrs. D, she is now back at the facility after she was in the hospital. So she was there. What did she get? An indwelling Foley catheter. It was in there for several days. The catheter's out. She's feeling okay, but she doesn't have any voiding signals, and she's incontinent. And so that is upsetting her, as you can imagine. So on the next slide, I just want to point out with this particular case is that this is a good example where someone who used to have signaling about their urinary voiding loses it. And whereas some people will say, well, once it's lost, it's lost. And I've met many of people with chronic urinary incontinence who we feel like they can't regain any of it. I want to point out that bladder training can be effective even for people who have chronic urinary incontinence. Kegels is the name. So this is an example where you need to call your physical or occupational therapist and get them on the team and help you with that. Some people think older adults aren't good candidates. That's not true. There's similar success rates in certain older adults, so don't discount that. Timed voiding is also a really important part of helping someone in this case. And that's where your bladder diary could really come in handy, because knowing what the routine is, you would be able to sort of set up a strategy for when she might need to be taken to the bathroom, and set up a schedule of when you would take her to the bathroom, help her see what she can do to regain that ability to void. And then it also brings up the concept of some individuals who have certain amount of incontinence during the day and larger amounts at night, or vice versa. There are nowadays a really good array of products that are specific for daytime and nighttime. And it's been very impressive to me to see how strategically choosing undergarments can sometimes be very pleasing to patients and the staff who are helping take care of them, because of the way that they are able to help someone with that all-important dignity issue here, because this is certainly a symptom that none of us want someone to be facing. So I think with that, rapid fire cases, the next slide is just a big thank you. And I really do appreciate the time, the folks from CENI helping give us this time. I think I appreciate that for all the reasons we've just talked about, both the big sort of concepts of person-centered care, don't ignore urinary incontinence, realize that there's a lot more we can do these days. There's a lot more products, there's a lot more help about how we take care of these patients. So I thank you for all being out there and doing the kind of work you do, and wish you well. Happy to take other questions. Thank you.
Thank you. So we are at the top of the hour. Dr. Laird, we have about 8 questions in the Q&A. Would you be able to answer them via email?
Oh, absolutely. I'd be happy to.
Okay, so for everyone, we will send the recording out in the next 24 hours. It'll come to your email, and that you'll have both the recordings and the handouts that go with the recording, so they can be used for continued staff education. And those recordings will be about 15 or 20 minutes. I invite you to check out the Greenhouse Project website for further education. And if you are interested in getting those nursing contact hours, check out the chat. Check out the chat box. Janet will put in the link to get those contact hours. So that's important to finish the evaluation and be on the entire webinar to get those hours. And I just want to shout out that Deanna from CENI shared that if there are organizations that are interested in trialing the CENI incontinence products, that they're willing to share. So if you're interested in that, if you put a quick note in the chat, or else call or email me, I'm gonna put my email address here in the chat box. So thank you so much for joining us today. I appreciate your time. Have a great day.